Hang on, now I gotta. Yeah, I know. Hi, everyone. We are experiencing some technical difficulties again. Apologies. Lou will be joining us momentarily. We just need to figure some stuff out on his end. So just hang tight.
Okay.
Oops, I think I forgot to mute us for the other drama that I was talking about, or at least mute me.
No, that's fine. All right.
That's fine. Well, anyway, okay, everybody. Thank you so much for joining us. We are now live. I hope. Yes. And today we're going to be talking about for hospitals in hospitals vetting 503Bs. And I just want to say that I had actually been talking to somebody else about topics that they want to hear in conferences, doing my research. And this is one of the topics that came up. And I was like, oh, well, as a matter of fact, we are going to be covering that. So Lou had told me this was timely and he's seeing a lot of things. And so I'm really looking forward to this, and I hope I think it's going to be relevant and important for a lot of people. Lou, why don't you introduce yourself, and then you can also give us a little bit of a background on why you think this is an important topic, what you're seeing out there.
Sure. Good afternoon, everybody. Again, apologies for the technical stuff. I am Lou DiOrio. I'm the principal and president of LDT Health Solutions. We are an international pharmacy, regulatory, and med safety consultancy based in New Jersey. And we have, for the last 16 years, been in and around all things compounding, and with a special emphasis on FDA. So, in speaking to Vivian, and one of the things that we have been talking to our clients about is, with the complicated and fragile drug procurement chain, supply chain that we have, how does a hospital in particular, and this extends down to physician practices and ambulatory infusion operations, how do you get a verified, validated source of particularly compounded sterile and also compounded non-sterile non-sterile product. And one of the things is that there's this big misconception out there that 503Bs are somehow manufacturers, and that is incorrect, right? If you really look at the FDA website, if you look at the Drug Quality and Security Act, you will quickly realize that buried in its 700 or so pages is the fact that a 503B is really an outsourcing facility. It's an establishment that was created by the law, but it is not a manufacturer in the way Pfizer or any large Moderna, any large manufacturer is set up. So you immediately you've lost all the protection of product liability, right? So you really need to understand that when you take in a compounded prep from one of these providers, that you're assuming the same responsibility as if you compounded it yourself. So therefore, the vetting of your provider is key for you to mitigate as much risk as you can. And that's really where the conversation starts, right? So if you're going to extend your liability to include this contract compounder, for lack of a better term, how do you do that intelligently? And how do you do that as safely as possible, right? And we all know that the business of healthcare in this litigious universe that we live in is never going to be zero, right? We can never wring out all of the possible risk, but without a clear vetting protocol for the 503B or the 503Bs that you use, and and speaking to some of our larger clients, it is multiple 503Bs. I think one of the things that the COVID crisis sort of highlighted, and one of the things that we learned from the drug shortages going back 3, 4, 5 years, was that going prime vendor or going sole source is not in the best interest of a hospital, right? There's just no way that someone could provide everything you could possibly need. And in the post NECC universe, and with the FDA as active as they are in the 503B field, as demonstrated by recent shutdowns and large recalls, you really need a backup to your backup. So
we have a question. I don't mean to interrupt you.
No, go ahead.
They want to know if can 503Bs start with NS API for sterile production or only finished dose?
They can do both as long as they registered with the FDA and disclosed that they're going to use bulk substance, and that is clear on the FDA webpage. So if you go to the outsourcing webpage of the FDA website, one of the columns to the right will tell you that. But yeah, they'll use both.
Okay, sorry, I didn't.
No, and it's fine. There are a few 503Bs that actually have parallel products. They'll offer 2 offerings that have the same active ingredient, and you'll notice that there are 2 different price points. And one is from bulk substance, and the other one is from finished pharma, and that kind of explains it. Because when you're working from a finished dose, your cost of materials starts at a higher point. And you need to, they need to disclose that. You need to ask that. So that's a really great question.
Okay. So let's then go in the process, because when I was talking to this person, one of the things that she said she sees a lot is that when a hospital is vetting a 503B, often they just look at their balance sheets and they're like, oh, the company looks good, or something like that. They just look at the paperwork in their quarterly sheets. They don't actually go to the facility and they don't actually walk through. So do you see that, or what are some of the problems that you're seeing when the hospitals, or the
Yeah,
lack of
I mean,
knowledge that hospitals are?
if you're only looking at their fiscal strength, then you're doing your due diligence to invest in that company. You're not doing your due diligence to purchase service from them. I was discussing this with the editor of Pharmacy Purchasing and Products magazine the other day, Deanne Halverson, and we were talking about, I guess when 503Bs first hit the scene in November of 2013, right after the law, right after Obama signed it into law. You know, PP&P magazine put out their annual survey, and I was always amazed. The one question that they always asked that always amazed me was, for the folks that are purchasing from 503Bs, how many people go on site? And that number was pitiful. It was less than 10%. And then for about 5 or 6 years, it sort of stabilized at about 20%. And we dug into that, and there's 100 reasons, or there's 100 excuses that were given. Some was lack of resources. Some folks were talking about their hospitals, their hospitals policy on travel, or their hospitals policy on gifts, right? Because a 503B would be, if you're serious about purchasing from them, they will be more than happy to give you a couple of plane tickets to come and do a dog and pony show. So with all of that complexity, it sort of fell out of favor. But I think now we've flipped that over, and we're hovering about 80% of folks will go and do some sort of diligence, whether it's remote diligence or some sort of Zoom meeting or something. But I can't stress enough that if you can get boots on the ground, get boots on the ground. Now, before you go boots on the ground, you really need to do some homework, because for the folks that do it for their hospitals, the comments we get back is, well, I flew to wherever, and I toured the facility. Doesn't look like my pharmacy, so I guess we're okay. Right. And that's not the standard, right? For somebody like me that does this a lot and goes in and out of different sorts of compounding operations on a weekly basis, I would claim a more discerning eye.
Well, that does bring me up to a question. A lot of these pharmacists or are the people who are doing the vetting, they're very familiar with USP, but are they familiar with the CGMP that the 503Bs have to be up to standard for? So if
Nope.
not, then what do they need to do to,
Right.
because that's what I've heard. They look and they're like, wow, this facility is great, because they're comparing it to USP, but they don't really know what they should be looking at or looking
Right.
for.
And also, if even if you, like, we talk about this with clients, and it's you need to build. There's no tool that I can give you. There's no tool that's available. And there used to be some older ones from ASHP and some other organizations. They used to give you a tool or a list of questions to ask. And what I would say is that's a great starting point, but you need to do two things, right? You need to eliminate the bias of the person, right? If we go on the premise that you can't send 100 people, you can't send the entire pharmacy leadership team. So you're going to send 1, 2, maybe 3 people. So to eliminate the personal bias from those 1, 2, or 3 people, what you really need to do is to find a tool, or to start to build a tool. And we've provided several of these written tools in some of the stuff we publish. Some of it is in pppmag.com, Pharmacy Purchasing Magazine. You can download that tool, but there's no tool that anyone can give you that you can use off the rack. You really need to sit down, go through that checklist, go through that tool, and make sure that all of the things that are important to you and your organization are represented on that tool. And then to remove the personal bias, it is totally appropriate to spread that tool out to your entire team and have them look for gaps, look for things that are not being asked, and to add them. That way, when you get on site, you are not, suddenly distracted or enamored with all of the stainless steel and the shiny lights that you see like a child in a candy store, and get off task. The other thing is that um, working from a fixed tool also allows you to make a running list of documents that you're going to request during that meeting and keep track of those. And that's key. So we can run down a quick outline if you'd like about
Yeah, I'd like to do that. I also want to see ask you what some of the most egregious things that you're seeing. So, I mean, give us some working examples of.
Right. So, I mean, it's it's the lack of, when it comes to running a 503B, when that was my job, and when I did that for a living in a previous life, for me, it was all about the control process, right? It was all about traceability, trackability, and recallability, right? So if you talk to somebody and you ask them about their 503B, they will, and you ask them a simple question. Hey, does your 503B have, modern labeling? Is the labeling, sufficient for your hospital? And they'll say, yeah, that labeling is great. There's a barcode on it. And you go, well, okay, what's in that barcode? What does that barcode represent? Oh, I don't know. I never really asked, so it's, okay, you checked off the box that they were barcoded labels, but does that barcode contain information that your inventory system can use? Does that barcoding label contain any information that your Alaris pump system or whatever pump system the hospital is using can use? Things like that. When you start drilling into those details, those become the differentiators, right? So we're seeing a gross lack of, it's sort of carelessness on the part of 503Bs for their labeling and their labels. That's obvious. The second one is a weakness in their protocols for cleaning and disinfecting. And those have been identified by the agency over and over again. I think once you start to drill into and ask for training records of not only the pharmacist, but the techs that are working there, you'll get some eye-opening things. And it's not that you want to play gotcha. Again, it's that you really are assuming responsibility for dispensing this to your patient. So you could think of this really simply. At the very worst or the very best you can hope for is, in the case of a mistake or in the case of an ADR or some sort of event, you're going to be sitting in court right next to your 503B provider. And there's nothing you can do to remove yourself from that fiduciary responsibility. So you better do your due diligence.
So I have two questions. One is, we did a session on 503Bs vetting their suppliers. Should you be going over their vetting process of their suppliers? Like, how far do you need to go? And the other question that I have is about 483s. Now, I'm assuming everybody pretty much always has a 480. Everybody's got a 483 on something, right? So is it reasonable?
We've been clear on that in everything we've written. The presence of a 483 for any 503B provider doesn't exclude them.
Right. Okay. That's what I was going to say. So it's good to do your research. And then should the people, if they find the 483s, should they ask them about that? Kind of like, what did you do to fix it? Or would you say it's just not relevant?
No, it's absolutely relevant. So what you do is, and this is something that we do in building our database. There are 483s. In fact, I can tell you right now, as we sit here, there are 10 483s that have been issued to 503B facilities as of today that are not posted to the FDA website. They're nowhere. So one of the first things you should do is, as a preliminary sort of get ready for your trip to or your Zoom meeting with a 503B is to look at the FDA website on the recalls and warnings page and see if there are any actions, warning letters, or 483s that you can look at. If they're not, then the first thing you do when you come on site is you ask them for that 483. You ask them for any pending warning letters, any open business, or any recent business with the FDA. In fairness, then you also have to ask them for their response to any one of those documents. And you can make a judgment for yourself whether you think that their response was sufficient or not. Now, there are triggers that I have when I look at 483s, and I look at serialized 483s, right? Repeated 483s, repeated warning letters to the same 503B. Is it a different issue, or is it the same issue that's reoccurring? And if it is a reoccurring sort of serialized problem, why can't you close it up? Or, what's the story behind the story? And then you need to make a judgment as to whether their response makes sense, or do they have a systemic problem they can't get their arms around? I happen to have in front of me the 483 for Pharmedium. And I know Pharmedium has entered a consent decree and is no longer there, but talking about serialized problems, there is, and this document is available for public view on the FDA website. One of the things that brought down Pharmedium is that, according to this last 483, there were 632 opened out of specification citations that the FDA identified in their 4 facilities. There were over 300 in Memphis, about 80 in Cleveland, Mississippi, over 200 in Sugar Land, Texas, and 22 in New Jersey that were never closed or addressed. And that, if I had to guess, the logical mind would say that's part of the reason that they're no longer providing service to pharmacies. You need to make sure it's okay if the FDA identified a problem or a potential problem, what was done about it, and is it a closed item or is it a systemic reoccurring item? So you need to ask yourself that, and that's the jumping off point. For those of you out there that are Joint Commission aficionados, right, that you're very in tune with that sort of thinking, why don't you you can make your vetting exercise sort of a tracing exercise, right? So what you do is, before you leave for the 503B, pull some product that you're ordering from this particular 503B. Note the description, note the item number. Maybe you even want to bring a copy of the invoice or the manifest with you. And then when you come on site, ask the 503B to trace this back along its process. Here's the lot number that you sold me. I want to see the quality document, the release testing. I want to see information about the components, the API, the supplies. It was signed by a pharmacist and 3 techs. I would like to see the training record for that pharmacist and those 3 techs. Okay, can you tell me which of your 3 or 4 compounding rooms this was made in? Oh, it was made in room number 2? Can I see the environmental monitoring? Can I see the temperature and humidity data for that room? Can I see the cleaning logs for that room? Trace it back through the process and make sure that accountability and that control over process exists. And that'll give you, a better idea of how fastidious these folks are and how much control they have over their process. That would be an interesting, if you don't want to go off a dry checklist, do a product tracing and then see where that takes you. That's also a strategy.
That seems like an excellent idea. That really does. That really will take you through everything.
I don't think that depending on a GPO report anymore, even if they're doing those, I think one of the things that COVID sort of exposed was service weaknesses with your average group purchasing organization. So in the past, or when the marketplace first got established, a lot of folks, sort of made the assumption that they're using their GPO to vet suppliers of goods, that they could use them to vet suppliers of service. And I think that is really dangerous. And I'm not really aware of any of the large GPOs that actually do it anymore or do it consistently. So be aware.
Right. Does anybody else have any questions? We're pretty much, our time is almost up, or is up actually. I'm wondering, should we touch on the tools? Is that a whole conversation? And I'm also curious about the Zoom. I'm wondering if we should touch on those quickly, or we should set up another call to go over those.
Well, either way, we can sort of, why don't we do this? Why don't we leave it as a homework assignment? I mean, we've just published published a bunch of articles on vetting and due diligence.
Oh, good. Okay.
One will be released after this podcast is rebroadcast. One is already out there in the current issue of PPNP, and it's called, what is it called? It's called Trends in Regulatory Actions for 503B Compounders. So that'll give everybody on this pod sort of good background about what is being identified as systemic problems in all 503Bs, and then that may be a good starting point when you're going to do your due diligence at your 503B.
Okay, good. And can we post those on LinkedIn?
Yeah, we can certainly post links to those. Not a problem.
All right. Well, thank you very much. Greatly appreciated. Sorry about the challenges getting on, but
like Shakespeare said, to err is human, to really mess up, you need a computer. So we'll figure it out.
Thanks. I'm 2 for 2 weeks. I had a couple of good runs and then 2 weeks in a row problems, but such is life. All right. Well, have a great day, great rest of the day, and a great weekend.
Thanks
everybody for joining us. Bye.